Good morning, everyone. Thank you for joining with us with another academic session. Today's lecture is on management of pleural effusion, and Dr. Bodhika Samarasekera, sir, is going to do the lecture. He's the immediate past president of Sri Lanka College of Pulmonologists, consultant respiratory physician at DGH Negombo. He graduated from University of Sri Jawatanapura in 2001 and obtained his MD in medicine from the University of Colombo. Dr. Samarasekera completed his local training at the National Hospital of Respiratory Diseases, Valisura, in 2011 to 2013, and his foreign training at Heart of England NHS Trust, Birmingham, UK, in 2014 to 2015. Following the completion of his MD, he was appointed as a consultant respiratory physician of the teaching hospital, Jaffna, followed by DGH Hambantota, Gampa, and then Negombo. Dr. Samarasekera has held the position of Joint Secretary of the Sri Lanka College of Pulmonologists for 3 consecutive years, 2018, 20, 22, and the position of Treasurer of the College in 2019. He is currently a member of the Specialty Board in Respiratory Medicine of the Postgraduate Institute of Medicine. He is also a trainer and examiner for Diploma of Tuberculosis and Chest Disease conducted by the Postgraduate Institute of Medicine, Colombo, while being a visiting lecturer of Faculty of Medicine, University of Moratuwa. He also contributes as a member of editorial board of the National Latent TB Guideline and Extra Pulmonary TB Guideline. So, I kindly invite you, sir, to conduct the lecture. Thank you.
Thank you, Dr. Anish, for very kind introduction. I think this is the first academic hour lecture after the new EXCO being appointed. So let me congratulate Dr. Sanjeev Tennakoon and Dr. Prabhat, the Secretary of the GMOA, Dr. Prabhat Sugadasa, for new appointment. And as an outgoing Vice President, it is my duty to thank Dr. Darshana Sirisena and the past president of the GMOA, and also Dr. Harita Alutge, the Secretary, and the previous EXCO for their excellent work done on members during last 2 years. And let me congratulate the new EXCO as well. Coming back to the topic, management of pleural effusion, one of the important topic because we commonly neglect the pleural effusions. Actually, it's a diagnostic opportunity for many diseases. So correct diagnosis and correct approach of pleural effusion is very important in clinical management of these patients. Pleural effusion, I will brief on diagnosis of pleural effusion and classification of pleural effusion. Also, thoracic ultrasound in new era, that it is playing a very important role in diagnosing and managing pleural effusion. And diagnosis and management of pleural infections, which is very common in our settings. And TB pleural effusion, which is after the COVID that TB cases are rising, and pleural effusion are also not uncommon. And malignant pleural effusion, which is also important in terms of especially the diagnosing malignancies as well as managing them palliatively and doing some procedures. Pleural effusions are a common medical problem, and pleural effusion is defined as accumulation of fluid in the pleural space that exceed the physiological amount of 10 to 20 milliliter of fluid, affecting over 3,000 people per million population annually. Pleural effusions are manifestations of over 50 underlying diseases. So it is very important to correctly diagnose these pleural effusions and also ordering investigations and procedure for do certain procedures to care of these patients. Pleural effusions can develop due to over 50 different etiologies. Pleural effusion can occur as a disease localized to the pleura, lung diseases, and systemic conditions such as SLE and all, organ dysfunction, and certain drugs. So occur as a result of increased fluid formation and reduced fluid resorption. 30% of pleural effusions can be multifactorial. It is very important to know about basic anatomy of the pleural cavity because it is very important to assessing these patients, and also diagnosis purposes we are doing aspirations. So the pleural cavity consists of it is in between the parietal pleura and the visceral pleura, and you can appreciate the intercostal muscles and ribs, and below the ribs you can see the neurovascular bundle. So it is very important to aspirating these patients that go above the ribs, so because that you can damage neurovascular bundle if you go beneath the rib. And more importantly, if you can, there are some variations also. So more importantly, that it is very safe if you can use the ultrasound. Nowadays, many centers are having ultrasound, so it is very important to use ultrasound in pleural procedures. So I'll talk about the unilateral pleural effusions, which is important because all unilateral pleural effusions, unless those very small ones, we need to aspirate these pleural effusions to diagnose underlying causes, because it's a very good opportunity to have some samples and get the underlying diagnosis. Very small pleural effusions, less than 1 centimeter depth at the diaphragmatic level, cannot be aspirated due to can damage the organs. So all effusions, small, moderate or large effusions, if you have enough fluid, so you need to aspirate these pleural effusions. So the common causes like parapneumonic pleural effusion, tuberculous pleural effusion, and malignant pleural effusions are the most common presentations in our setting as a unilateral pleural effusion. Bilaterally, that you can have heart failure, but you can get bilateral pleural effusions, and also kidney and liver diseases. So your history and examination is very important in diagnosing and assessing pleural effusions, because a cause may be apparent on history and examination, will guide the further investigations and will avoid unnecessary investigations. So you have to assess the comorbid conditions and signs and symptoms of pneumonia and TB. TB is very important, and you have to always ask when the patient with pleural effusion, the contact history of TB is very important. And symptoms and risk factors for malignancies, drug and occupational histories. We know that asbestos exposure can cause mesothelioma and also pleural effusion. So like that occupational history also important, and recent procedures and miscellaneous things. So it is important to get a good history and examination. The patients often present with pain of the affected side and also dyspnea and cough. On examination, you can get stony dullness on percussion, decrease or absent tactile parameters, and decreased breath sounds. And there can be ipsilateral pleural rub. And in a large pleural effusion, the trachea can be shifted to the contralateral side. So the basic investigations of pleural effusion is the chest X-ray. It is a must. And however, you need at least 200 to 300 milliliter fluid to get a chest X-ray features in pleural effusion. You can appreciate the concave pattern of this opacity, homogeneous opacity. And you need at least 200 to 300 milliliter of fluid to get the X-ray features, and also to get the clinical signs such as stony dullness, you need about more than 500 milliliter of fluid in the pleural cavity. For smaller pleural effusion, when the ultrasound facilities are not there, then you can order a lateral decubitus radiography, and you can appreciate here, like, that small pleural effusion. It's very apparent in this lateral decubitus X-ray. So more than 50 milliliter pleural effusions that we can diagnose in that way. So investigations of unilateral pleural effusion, it is important. If you have a unilateral pleural effusion on a chest X-ray, we can confirm by ultrasound, bedside ultrasound, which is available in many hospitals nowadays, and good history and examination, and then assess the patient whether he is breathless or not. And also if you do ultrasound, that you can appreciate a large effusion. So then you need to do a large effusion, you need to do a thoracosensitives. But you can tap these pleural, consider therapeutic pleural aspiration if it is a large effusion, maximum 1.5 liters, and then send the fluid also for analysis, because why you are limiting 1.5 to 2 liters is that they can get flash pulmonary edema. So when you aspirate too much of fluid in a unilateral pleural effusion. So, and if it is a small pleural effusion or a patient is not very breathless, so then you can do a diagnostic tap and thoracosensitivities, and you can send for investigations that you order. And even in large effusions, when you do a therapeutic pleural aspiration, it is better to keep some fluid in the pleural cavity, because, for example, this patient these investigations are positive for culture positivity or evidence of, I will discuss on later, evidence of empyema or complex pleural effusion. Then you can put an IC tube. So then it is important to have some fluid in that scenario. So thoracic ultrasound is very useful in diagnosis of pleural effusion. Available in many respiratory clinics and also wards nowadays. So this is a normal lung, which you can appreciate the normal lung tissues here and also ribs. So this is the normal appearance of the lung. But here there's a hypoechoic dark color fluid you can appreciate here. This is called this is a large pleural effusion. This is hypoechoic pleural effusion, which is simple, which is a uncomplicated pleural effusion, because there are no echogenic materials in this pleural effusion, and you can appreciate the collapsed lung here and also the diaphragm the other side. So this collapsed lung also important. Sometimes if it is too convex, like can end up with trapped lung. With good experience hands, you know that this pleural effusion, the aspiration, after aspiration, the lungs will expand. Ultrasound can demonstrate small pleural effusions, and the sensitivity is 100% for volumes more than 100 milliliter. Ultrasound appearance of pleural effusion is highly variable. There are 4 appearances based on internal echogenicity of the is recognized. So anechoic, I explained earlier, that's hypoechoic or anechoic, is a dark pleural effusion without any white patches, and complex but non-septated pleural effusion, and complex and septated pleural effusion, and homogeneously echogenic pleural effusions. So this is a simple non-echogenic hypoechoic pleural effusion, uncomplicated pleural effusion. And here, if you can appreciate, this is one of my patients, if you can appreciate here, you will see sand-like appearance. This sand-like, uniformly sand-like appearance is the increased echogenicity, is a sign of empyema. So you know that if you see this, like there's a pus inside the pleural cavity, which is an indication for a IC tube insertion. So that is why ultrasound is very important bedside investigation in a patient with pleural effusion. So that this is our patient, we aspirated, and you can appreciate pus here. So this patient needs IC tube insertion. Then when you send the fluid, you have to send fluid for all the investigations. Don't forget important investigations like in the biochemistry, that protein, lactate dehydrogenase, LDH, glucose, ADA, and pH also very important. We often forget the importance of the pH. I will discuss later on. And the cytology. Cytology important in 2 ways, like in the cytological analysis, you can find malignant cells, and also differential white cell counts. You can differentiate the cell count, and especially if it is TB, you can get increased number of lymphocytes. But for the cytological analysis, don't send small amounts of fluid for cytology. You need at least 50 milliliters of fluid needed for good analysis of the pleural effusion. In microbiology, you can send for gram stain and culture. An AFB stain, also you have to do, an AFB culture also you have to do if possible. But considering the gene expert, We do gene expert in sputum, AFP sputum, but pleural fluid, it is sensitivity less. But we need some further investigations on this because recently few of my patients, we did it and we got positive, but there's no evidence for that. We need further investigations on this. Gene expert is a very important investigation if we can do. So exudative and transudative pleural effusions you have to differentiate. In clinical practice, pleural fluid protein levels less than 25 grams per liter represent the transudate, more than 35 grams per liter represent an exudate. In borderline cases, the protein level, say it is 25 to 35 grams per liter, Light's criteria should be applied. So what is the Light's criteria? If pleural fluid is the pleural fluid is an exudate in the presence of one or more below Light's criteria. That is, the pleural fluid protein to serum protein more than 0.5 and pleural fluid LDH to serum LDH more than 0.6 and pleural fluid LDH more than 2/3 of the upper limit of the normal serum LDH. So I will discuss that serum LDH also very important investigation in management of pleural effusion. Later on I will tell you why. The common causes of pleural effusion, as you all know, the parapneumonic pleural effusion is common in our sittings. Malignancy, tuberculosis, pulmonary infarction, rheumatoid arthritis, mesothelioma are the exudative pleural effusions. But transudative pleural effusions are left ventricular failure, liver cirrhosis, hyperalbuminemia. These are usually bilateral pleural effusions. Less common causes like empyema, SLE and other autoimmune disease, post-cardiac injury syndrome, wrestlers, post-coronary artery bypass grafting, esophageal rupture, and the transudate like nephrotic syndrome, hypothyroidism, and pulmonary embolism and mitral stenosis. Rare causes also there, like yellow nail syndrome, which occurs with bronchiectasis and clubbing and yellow color fingers, and chylothorax, chylous pleural fluid, and certain drugs. Sarcoidosis and fungal infections can also cause exudative pleural effusion. Transudative, this constrictive pericarditis, uterothorax, Meeks syndrome, and ovarian hyperstimulation syndrome are a rare cause of transudative pleural effusions. Then we have to analyze the cell count. It is very important. Pleural fluid cell count, if it is more than 10% of the total nucleated cell count, is suggestive of air or blood in the pleural space. If not, it can be due to fungal or parasitic infections, drug-induced cases, pulmonary embolism, asbestos-related diseases, and Churg-Strauss syndrome. And also, when you consider cell count, the lymphocyte count also important to assess, like lymphocytic pleural effusions are common in extrapulmonary TB pleural effusions. So lymphocyte count also important in cell count diagnosis. So glucose concentration, glucose is important to diagnose. Glucose concentration less than 60 milliliter per deciliter is probably due to tuberculosis and also malignancies, rheumatoid arthritis, parapneumonic, especially complex parapneumonic effusions and empymas. So your glucose level will be low, less than 60 milligrams per deciliter. The pleural fluid pH is very important to assess. The exudative pleural effusion with low pH can be due to complicated parapneumonic effusions, empyema, rheumatoid pleuritis, malignancy, esophageal rupture, and tuberculosis. So why this is important is if your pH is less than 7.2 in the context of pleural infection, is an indication for urgent pleural drainage. Especially you have to put an intercostal tube in these patients. And that is why pH is very important. People are reluctant to do pH because, they will think that it will damage, that when you put the pleural fluid into the ABG machine, that they will think there will be a damage to the machine. That won't happen. And also, we want to do it without heparinization because the heparin can cause falsely reduce the pH value. And don't keep the sample when you're assessing the pH quickly taken into the ABG analysis because the machine, because if you delay to send the sample, then you will get falsely low values. Then other important biomarkers are pleural fluid AD and interferon gamma are useful in diagnosing TB pleural effusion. Both are equally good. And So I will tell you later on in the diagnostic when you're diagnosing TB pleural effusion, but don't forget to send ADA. Interferon gamma is not usually doing in our settings, but ADA is available. So in a high prevalence population, pleural fluid ADA and interferon gamma test can be considered for a diagnosing tuberculous pleural effusion. In low prevalent population, pleural fluid ADA can be considered as an exclusion test for tuberculosis, tuberculous pleural effusion. So ADA is very important to biomarker in assessing the pleural effusion, especially if you are suspecting TB effusions. Other biomarkers like NT-proBNP, not superior to serum NT-proBNP, so not routinely done, but ANA, pleural fluid ANA will support the diagnosis of SLE pleuritis. And certain circumstances, like we have to do, need to get the histological diagnosis in cases where pleural fluid analysis is not diagnostic. So we need to get the sample for a histology. You can do under direct vision, the medical thoracoscopy or a video-assisted thoracoscopy. Medical thoracoscopy is done by respiratory physicians and video-assisted thoracoscopy by thoracic surgeons. And close biopsies and image-guided biopsies, percutaneous biopsies with the help of the radiologist. So in medical thoracoscopy, this is the scope. Semi-rigid medical thoracoscopy, and this is one of my patients. So if you can appreciate that, you can directly visualize the lesions, like this is the malignant deposit over the diaphragm. So this we can easily take biopsies, and you can directly visualize the lesion and take the biopsies. So that is the advantage of direct vision, a medical or a surgical thoracoscope. But in cases like TB, so we can manage with close biopsies. Like good old days, we use the Abraham biopsy needle. They are indicated in cases of suspected pleural tuberculosis because there is a diffuse involvement, granulomatous pleural involvement. So diffusely involved. So at any point that you can get a positive biopsy if you do it properly. So, but closed pleural biopsies are less sensitive when pleural involvement is patchy. Especially I have shown the slide earlier that there was a patchy malignant deposits. So in that case, like you need to go for a medical thoracoscopy or a video assisted thoracoscopy to get a good sample. So when you're talking about the pleural infection is most commonly in elderly, but can occur at any age. It is twice as common in males. Up to 20% of adults with pleural infection have diabetes. Other important risk factors including aspiration, immunosuppression, alcohol abuse, pleural procedures, thoracic surgeries, and penetrating chest trauma. All these are risk factors. So in your history, it is important to assess all these things in your history and examination. So in a pleural infection, this, if you can appreciate here, that you have effusion and plus consolidation. This is the ultrasound scan. This is hyperechogenic areas. This is called septations in this pleural effusion. And if you aspirate, these septations occur in empyema, and also septations and loculation can occur in empyema and also the complex parapneumonic pleural effusion. When you aspirate, you can get pus or a turbid fluid in these sort of effusion. That's why ultrasound is very important in diagnosing and managing pleural effusion in this era. Sometimes we go ahead with the CCT also, and the complex long-term chronic effusions. This is one of chronic empyema surrounded by a pleural rind. So these are thick capsule-like, husk-like areas. So it is very difficult to manage with simple aspiration. So you need to put large tubes for these sort of patients. I will discuss this later. So this is a pleural rind. It's a feature of empyema. Management of pleural infection, you have to assess and start correct management protocols and broad spectrum IV antibiotics depending on the antibiotic guidelines, local guidelines, and chest tube drainage, nutrition support and supplement and thromboprophylaxis, and you have to monitor very carefully for worsening of sepsis for early surgical referral. Because surgical facilities are available, video assisted thoracoscopy are available at Valisera, so surgeons will help us, and it is important to refer early for the correct interventions. So what are the indications for chest tube drain? I told you that pleural fluid pH is less than 7.2 is a indication for pleural IC tube insertion. But Proteus infection is associated with high pH due to ammonia production, and also sometimes if you use, as I told earlier, if you use heparin, you will get falsely low values. And in addition, positive pleural fluid culture or gram stain, if you have purulent pleural fluid, and if you have loculations and septation on thoracic ultrasound, then you need to insert a chest drain on these patients. So this is like hyperechoic areas, septations, and also echogenic materials. When you aspirate this patient, also in one of our patients, the pus was aspirated. So how do you manage these IC tubes? Nowadays, like the other countries, developed countries using IC tube called Seldinger. We also had before COVID era, we use this at Gampa and also Valisera. This is very easy and less scarring and less complications, and we have a IC tube, very small, from 12 gauge to 18 gauge, and we have a guide wire and also a three-way tap and also the dilator. So we can easily insert these IC tubes, but there's a bit of a debate on that, like complex and empyema, septated, loculated pleural effusion. Are we going to go ahead with the large IC tubes? Like there was a debate that earlier it was, they believe like both are same. There was a debate between the surgeons and physicians, but now rare occasions that surgeons won. Now they say for a complex empyema, you need to use a large IC tube, which we use in surgical settings. So, but still, for a complex parapneumonic effusions and other causes, like you can use this Seldinger IC tube. This is the Seldinger. The importance of Seldinger IC tube is you have a three-way tap. You can flush it and you can take samples, and when there's a block also you can flush. And when you're doing pleurodasis in a malignant effusion, that you can easily do the procedure if you have a three-way tap. So this is the advantage of Seldinger over the normal IC tube we are using. We can divide the simple parapneumonic effusion, the complex and empyema. The fluid appearance is straw-colored or bloody in simple parapneumonic effusion, but the complex parapneumonic effusion, can be straw-colored, bloody or turbid. So empyema, it is frank pus. Pleural fluid gram stain, always negative in the simple parapneumonic effusions, but complex parapneumonic effusion, it may be positive, and also empyema, it may be positive. The pleural fluid pH, usually more than 7.2 in simple parapneumonic effusion. Usually it is less than 7.2 in complex parapneumonic effusion. Obviously that you don't need to measure pH in empyema, because you obviously visualize the pus, so you can put IC tube on these patients. Pleural fluid culture will be negative in simple parapneumonic effusion, may be positive in complex parapneumonic effusion, and empyema also may be positive. Thoracic ultrasound appearance is very important, usually anechoic. I told you, I have shown you earlier, hypoechoic and no pleural thickening in simple parapneumonic effusion, it is black color. But complex parapneumonic effusion may show variable echogenicities, hyperechoic, white areas, and septations and loculations. And empyema often homogeneously echogenic, like sand-like appearance, as I have shown in a previous slide. Usually evidence of pleural thickening, loculations, and septations may be present in empyema. So what is the immediate management? Effusion usually resolved with antibiotics for pneumonia alone. Intravenous antibiotics and chest tube drain is needed in complex parapneumonic effusion, and empyema, intravenous antibiotics and chest tube also needed. And so usually the complex parapneumonic effusion or empyema, you need long-term antibiotics, IV, and also can be changed to oral, but you usually need more than 1 month of antibiotic therapies. So when you have a suspected pleural infection, these BTS guidelines, if you have not seen the frank plus pus, fluid is not frankly purulent, immediate pH assessment is needed, and pH, if it is less than 7.2, is a high risk of complex parapneumonic pleural effusion or empyema, pleural infection. So you need to put an IC tube for these patients. So the pH less than 7.2 is urgently you have to put IC tube, but the pH is 7.21 to 7.39. There is an intermediate risk for complex parapneumonic effusion, and then check the pleural fluid LDH. Usually you are sending with your other investigations. So if LDH is less than 900, there's no indication for immediate ICD. What you need is to closely monitor these patients to development of sepsis. But LDH is more than 900, again, you have to consider ICD, especially if any of following are there, like large pleural volume, fluid volume, lower pleural fluid glucose, less than 4 millimoles per liter, and pleural contrast enhancement CT. I have shown that like this pleural rind or enhancement of in CT and septation on ultrasound. So these are the indication if even the pleural pH is 7.2 to 7.39. If one of this is there, like that you have to, with a LDH more than 900, it is an indication for a IC tube insertion. pH, if it is more than 7.4, there's no indication for immediate ICD, but you have to monitor for the clinical progression. So earlier, we know that in complex parapneumonic pleural effusion or empyemas with septations, we did intrapleural streptokinase administration of intrapleural streptokinase for these pleural effusions. But however, now they say they have done the MIST-1 trial, multi-centered this MIST-1 trial didn't show any benefit versus placebo versus streptokinase. There was no difference in terms of mortality or in terms of surgery. So the multi-centered intrapleural sepsis trial, MIST-1, they conclude that no benefit of streptokinase installation in complex parapneumonic pleural effusion, which has septations and all. Initially, we may think that this works because we know by experience when you instill the streptokinase following day, like there's drainage is more. But however, like long-term studies, they have proved that there's no benefit versus placebo. So they are now not they are not recommending streptokinase for this purpose. However, then the MIST-2 study, they use intrapleural use of tissue plasminogen activator and enzyme called DNase combination. So that has proven mortality benefit, and also the change the size of baseline pleural shadows by CT or chest X-ray or ultrasound. So then, using this combination, tissue plasminogen activator and DNase have reduced the effusion, and there was mortality benefit and also the reduced referral for surgery. But TPA alone or DNase alone is equal to placebo, so there's no much benefit. So now they recommend MIST-2 study that TPA DNase combination for septated effusions, which has a mortality benefit and also reduce hospital stay and also reduce the incidence of surgical referral. So combination of tissue plasminogen activator and DNase be considered for the early treatment of pleural infection in adults following discussion of the risk and benefit with the patient. Saline irrigation also can be considered for the treatment of pleural infection in adults when intrapleural fibrinolytic therapy or surgery is not suitable. Because these enzymes are very expensive, it is not available in our country. So we can use these saline irrigation methods, and also single agent tissue plasminogen activator or DNase should not be considered for treatment of pleural infections in adult. Streptokinase should not be considered for treatment of pleural infection in adults as per MIS-1 trial. So streptokinase is no longer benefit for septated pleural effusions. Then we do these early, there's no early recovery, and then early referral for surgical team is important. There's another study going on versus intrapleural enzyme therapy versus early referral for VETs called MIS-3 trial. So early referral is very important because the surgeons can help us in case of these patients, and they can do decortications and also do surgery for the improve the prognosis of these patients. Then the other common pleural effusion in our setting is the tuberculous pleural effusion. Exudative effusion with lymphocytic predominance occurs in this pleural effusion. The yield of direct smear of AFB is low, and AFB culture should be performed. In non-smoking young patients, elevated pleural fluid ADA strongly suggested tuberculous etiology, especially when MAN2 is also positive. In an endemic area of TB, ADA levels more than 50 is strongly suggestive. However, non-endemic area, TB is virtually excluded if ADA level is less than 35. So ADA cutoff is 35 is important. And if ADA and MAN2 is there, then we can start ATT treatment. And also, if it's supported by lymphocytic pleural fluid lymphocyte, then it is highly suggestive of TB pleural effusion. But some patients need pleural biopsy. Close biopsy is enough, as uniformly, diffusely involvement of pleura is there. So anti-TB TB can start if following investigations are positive, even without a biopsy. Treatment given for 6 months, that's MAN2 test, positivity in more than 10 millimeter, lymphocytic pleural effusion, lymphocyte predominant pleural effusion, and also pleural fluid ADA more than 35. So MAN2, you have to know how to read this MAN2, oftenly misinterpreted. So in a MAN2 reading, you have to read only the induration. So not the redness, induration only you have to read, and you have to take the horizontal diameter. So it is important to keep this in mind. And then the management of malignant pleural effusion, more than half of the patients with malignancy present with a pleural effusion at some time in their course. Recurrent malignant pleural effusion impair the functions and worsen the quality of life. We often forgotten the palliative medicine in Sri Lanka. So in all respiratory diseases, the palliative care also important. Once patients malignant pleural effusion, the only present with malignant pleural effusion, only mechanical drainage can relieve the symptoms. So you have to aspirate, and you have to put IC tubes, and you have to properly manage that effusion. So once malignancy is confirmed, we can do pleurodesis. That's you can stick the pleura together with a sclerosing agent, and through the IC tubes that we can insert this talc and keep the IC tube for about 48 hours after insertion. Then remove the IC tube. Then there will be and the pleura will stick together, and it will avoid the accumulation of the fluid and relieve the symptoms of patients. And when talc is not available, there are other sclerosing agents as well. We can use doxycycline or tetracycline. But it is important when you're doing the pleurodesis that the patient should be pain-free, and it is a very painful procedure. So first you need to instill lignocaine and before talc, and also enough sedation and pain relief is needed. Other countries, they use, for malignant pleural effusion, they use indwelling pleural catheters. You can do at one-stop pleural clinic that you can do at one daily procedure. So this is the track, and the indwelling pleural catheter is stay there. And also, whenever fluid accumulates, and ultrasonically you can assess, and you can put this vacuum bottle and remove the fluid in an outpatient clinic, or else the nurses can visit and do in other countries. So this is very important procedures especially in malignant pleural effusions in a palliative care setting. In conclusion, ladies and gentlemen, pleural effusions are a manifestation of under 50 underlying diseases. All unilateral pleural effusions should be aspirated unless they are very, very small. And pleural aspiration should be done under ultrasound guidance. Pleural fluid pH analysis is a must when suspecting pleural infection. Complex pneumonic pleural effusion should be treated with intercostal drain if pH is less than 7.2, along with some evidence of, if there is evidence of infection like culture positivity or a gram stain positivity or a frank pus. So you need to insert an IC tube. And all suspected TB effusions should be guided by a MAN2 test and pleural fluid ADA, and the pleural fluid analysis of the lymphocytic pleural effusions, MAN2 test positivity and ADA more than 35. You need to start anti-TB. If they are not responding, then you can reassess these patients ultrasonically, and also and imaging can be arranged. And in malignant pleural effusions, don't forget to do pleurodasis, refer to pleurodasis with talc or intrapleural catheters. I am sure it will be available in our settings in near future. So should be considered in malignant pleural effusions. Thank you again for the GMO academic team and for giving me this opportunity. And it is a great pleasure to be here at GMO again to deliver this lecture. Thank you very much.
Thank you very much, sir, for that enlightening lecture. And I think...
are there any questions I can?
Yeah. There are a few questions over here, sir. In pleural effusion, due to liver cirrhosis, will you advise to drain? What is the best method? When IC tube insert, we have noticed poor outcome.
Yeah, well, that's a very good question because it is a very difficult to manage pleural effusion when there's liver cirrhosis, especially that when you're doing the procedures, they have high INR and all. So we usually, but patient is symptomatic, still we are going to aspirate these effusions. So a large fluid we aspirate. Usually that when you're doing the peritoneal taps also, that fluid, because in liver cirrhosis there's a because the fluid accumulates in the pleural cavity because of the connectivity of the pleural and peritoneal cavity. So when peritoneal aspiration been done, then there will be the pleural aspiration will reduce, but if it is not occurs, like we usually aspirate also, right. And we can refer these patients to thoracic surgeons for a long-term care. But unfortunately, it's very difficult to manage pleural effusions in cirrhosis.
So thank you so much again for that excellent lecture and for opening our eyes in how to manage pleural effusion and guiding us with its management. And hope to see you again with another excellent lecture as such. And we'll meet you again with another excellent lecture with our CPT program. So until such time, have a good day. Thank you.